Assalamu alaikum. Auzu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Rabbi zidni ilma, Rabbi zidni ilma, Rabbi zidni ilma. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Okay, arrhythmia and heart block. Okay, SVT, supraventricular tachycardia, refers to any tachycardia originating from above the bundle of hairs. This is high health. If any tachycardia arising above the bundle of the hairs, if any tachycardia arising above the bundle of the hairs includes a sinus tachycardia, multifocal atrial tachycardia, atrial flutter, atrial fibrillation, AV nodal, atrioventricular nodal reenter tachycardia, and junctional tachycardia. These all tachycardia originating above the bundle of the hairs, and these all are narrow QRS complex tachycardia. Common causes of regular narrow QRS complex supraventricular tachycardia include sinus tachycardia, atrial tachycardia, atrial flutter, AVNRT. So these were narrow complex tachycardia. What is the narrow complex tachycardia? Atrial flutter, atrial tachycardia, multifocal atrial tachycardia, sinus tachycardia, AVNRT, junctional tachycardia. These are all narrow complex tachycardia. Then paroxysmal supraventricular tachycardia are SVT with abrupt onset and offset. Abrupt onset and offset in paroxysmal supraventricular tachycardia, P waves are usually buried. P waves are usually buried within or seen just after the QRS complex. It is buried. A P wave is usually buried within or after or seen just after QRS complex. In patients who are hemodynamic stable, the next step in such a case to identify the type of the SVT with the vagal maneuver like aortic sinus massage, like Valsalva, like cold immersion or diving reflex, eyeball pressure, or IV adenosine. These are all the treatment can be given. These are the treatment can be given in SVTs. What are the treatments? You can give carotid sinus massage. You can do Valsalva. You can give cold water immersion, or diving reflex. You can give eyeball pressure, or you can give adenosine. Adenosine. Adenosine or vagal maneuver temporarily slow the contraction. It temporarily slow the contraction via the AV node and can be useful identifying P wave to clarify diagnosis of the atrial flutter or atrial tachycardia. They can also cause transient AV nodal block and terminate AV node dependent arrhythmia, including AVNRT and orthodromic AVRT, or orthodromic AVRT. Okay, supraventricular arrhythmia, mostly narrow complex tachycardia. It is narrow complex. QRS complex is if QRS complex is more than 120 millisecond. That means if QRS complex is more than 3 small square, it is considered as It is considered as wide complex. It is considered a wide complex. In here, the QRS is very narrow. QRS complex is very narrow. We know that normal QRS complex is 80 to 100 millisecond. If it is below 80 millisecond, then it is considered as narrow QRS complex. If it is more than 120 millisecond, it is wide QRS complex. Very simple. In narrow QRS complex tachycardia, as it is narrow QRS complex tachycardia, there are no regular P wave. In here, you can see there are no regular P wave as they are buried within the QRS, as they are buried. Retrograde PRS pseudo is these retrograde P wave, retrograde P wave. Sometimes P wave is buried within the QRS complex, and retrograde P wave seen in the beginning or end of the QRS, in the beginning or end of the QRS, when atria and ventricle are not simultaneous. Atria and ventricle are not simultaneous, can appear as spikes on the QRS complex. It can appear as the spikes on QRS complex or as inverted P wave. Very atypical. Now, sinus tachycardia. We know that sinus P wave present, that means sinus, and if the rate is more than 100, then it is sinus tachycardia, and characterized by SA node discharge rate, SA node discharge rate more than 100, SA node discharge rate 100 to 180 per minute, and regular RR interval, normal P wave and QRS complex, normal P wave, normal QRS complex. It is due to increased sympathetic, and decreased vagal tone in response to physiologic, and there are some pathologic cause like fever, hypovolemia, and thyrotoxicosis. These things we will discuss in detail. That what are the cause of sinus tachycardia? What is the cause of sinus bradycardia? Tachycardia if heart rate is more than 100, bradycardia if heart rate is less than 60. It may be physiological, like if you do exercise, if there is pain, then the heart rate may be increased. If you are excited or anxiety, if there is hyperdynamic circulation like fever and hyperthyroidism can cause sinus tachycardia. And there are some medications like beta agonist, salbutamol, and some sort of vasodilator, and can cause these. And the pathologic cause is atrial fibrillation, atrial flutter, SVT, atrial fibrillation, flutter, SVT, and ventricular tachycardia is also caused. What are the cause of sinus brady? If you are sleeping, if you are athlete, if you are hypothyroid, if there is beta blocker, if a digoxin, if there are, that means B, C, D's, beta blocker, calcium channel blocker like non-dihydropyridine calcium channel blocker, that means cardioselective calcium channel blocker, that means verapamil, diltiazem, and the digoxin. Digoxin can cause gynecomastia also. The side effect of digoxin. The pathology is carotid sinus, hypersensitivity, sick sinus syndrome, second degree heart block, and complete heart block. These are all can cause sinus bradycardia. So sinus P wave, if the heart rate is less than 60, think about bradies. Sick sinus, second degree heart block, and complete heart block. Sick sinus, second degree heart block, and complete heart block. Okay, this is sinus tachycardia. P wave present. P wave usually This is P wave before QRS complex, ventricular rate more than 100 beats per minute, 300, 150 less than. We can count like one small square, 300, 150, 100, then 75, 60, 50, like this. If you want to count the rate, and P-wave is usually upright in lead 1, lead AVL, lead AVF, in this lead, in lead 2 also, and V3 to V6. Maximal heart rate sinus tachycardia can be determined by beats per minute 220 minus age. Beats per minute 220 minus age. Now AVNRT, it is the most common cause of paroxysmal ventricular tachycardia. Paroxysmal develop in young patient less than 14 structurally normal heart. Palpitations uh, are the most common palpitations palpitations are the most common presentation, but some patients may have dizziness, shortness of breath, so chest pain, shortness of breath, hypertension, confusion, such sort of feature may be seen. AVNRT is due to presence of two conduction. This word is very high in most of the question. This word AVNRT is due to presence of two conduction pathways, slow and fast. In the where in the AV node there is two conduction pathway in the AV node, slow and fast. Normally sinus beats are conducted in anterogate direction. Sinus is anterogate, and sinus is anterogate direction through the fast pathway. Sinus is anterogate direction through the fast pathway, as anterogate conduction through the slow pathway is extinguished due to presence of refractory beat. If atrial premature beat occurs at a critical time when fast pathway is refractory but the slow pathway is not, if the fast pathway is refractory but slow is not, it can initiate AV NRT, that is then sustained re-entry of the mechanism. The slow and the fast pathway from a looped circuit formed a looped circuit with impulses traveling into the anterogate direction through which slow pathway and returning through the fast pathway. Vagal maneuver increased parasympathetic tone results in temporary slowing of the conduction in the AV node, an increase in the AV node refractory period leading to termination of the AVNRT. So vagal maneuver increase parasympathetic tone and result in temporary slowing of the conduction in the AV node. An increase in the AV node refractory period leading to termination of the AVNRT. ECG shows a regular rhythm with a rapid rate, no pre-wave. Atrioventricular nodal slow pathway ablation is used to. This is supraventricular tachycardia. 300 more than 150 RR regular, rate more than 150, rhythm regular. There is no P wave, or P wave is buried here. This is the conduction during normal sinus rhythm. Conduction during normal. This is fast pathway which has long refractory period. This is slow pathway which is short. Fast, long, short, slow. Slow pathway, short refractory period. This is AV node. This is bundle of His. Impulse from slow pathway is blocked. But what happens in here? In here, fast pathway. In here, fast path is still in the refractory period. Still, it is still in the refractory period. Premature atrial conduction. Uh, Premature atrial conduction impulse. Premature atrial conduction impulse. Premature atrial conduction. Premature atrial contraction impulse conduction down the slow pathway. So conduction fast pathway initiate re-entry circuit. Normal impulse already go through the circuit, and there is retrograde conduction to atria. P wave is buried and QRS complex. There is re-entered circuit perpetuates. There is again re-entry circuit perpetuates. This is the abnormal conduction leading to re-enter again. Then the WPW syndrome, Wolff-Parkinson-White syndrome. In Wolff-Parkinson-White syndrome, there is an accessory pathway of the bundle of the Kent, that directly connects atria to the ventricle, bypassing the AV node. Atria to ventricle bypassing the AV node. Anterogate conduction through this pathway with resulting pre-excitation of the ventricle produce characteristic ECG changes. Short PR interval. Short PR interval generally less than 0.12 seconds. There is slurred and broad upstroke of the QRS complex. There is slurred upstroke of the QRS complex, which is known as delta wave. QRS interval widening, sometimes leading to wide complex tachycardia with ST or T wave change. Most patients are asymptomatic, however, WPW can be associated with cardiac arrhythmia if there is retrograde conduction from the ventricle to the atria. A re-entered supraventricular tachycardia may occur. ECG features of WPW will not apparent during episodes of SVT, but the delta should be visible once the rhythm is slowed. Sudden conduction can occur if sudden death can occur if WPW is not treated. Short PR interval, there are two DDs. Wolff-Parkinson-White syndrome and uh, Long-Gannon-Levine syndrome. In WPW syndrome, there is short PR interval. In Long-Gannon, there is also short PR interval. The difference is there is a delta wave, that slurred upstroke. That's a slurred upstroke, presence of slow upstroke of the QRS complex. Presence of slow upstroke of the There is a slow upstroke of the QRS complex. But in Long-Gannon-Levine syndrome, there is no such thing. This is delta wave. PR interval is less than 120, less than 3 small boxes. This is paroxysmal supraventricular tachycardia usually. An accessory pathway conducts depolarization directly from an accessory pathway. In here, there is an accessory pathway Depolarization directly from atria to the ventricle without traversing the AV node. Atria to ventricle without traversing the AV node. AFib occurs in 10 to 30% of the individuals with WPW is a potentially life-threatening emergency. Atrial fibrillation in WPW can bypass the actual rate-limiting function of the AV node, leading to very rapid ventricular response, which is which is persist can ultimately deteriorate into the VFib. Actual acute treatment of atrial fibrillation in patients with acute treatment of atrial fibrillation with WPW, which is aimed at prompt control of the ventricular response. If hemodynamically unstable, electrical cardioversion. If patient is hemodynamically stable, rhythm control with antiarrhythmic. This one, ebutalide and procainamide. This one is very high. In patients with atrial fibrillation, in patients with WPW, acute treatment, patient has WPW, now atrial fibrillation. The drug you choose is procainamide or ebutalide. If immunologically unstable patient, acute treatment of atrial fibrillation in patients with WPW is aimed prompt control of the ventricular response. Uh, atrioventricular nodal blockers such as beta blocker, calcium channel blocker, and digoxin, adenosine should be avoided as they can cause increased conduction through the accessory pathway. Now, MAT, multifocal atrial tachycardia, exacerbation of the pulmonary disease COPD, electrolyte disturbance, hypokalemia, and catecholamine surge sepsis. Exacerbation of the pulmonary disease COPD, electrolyte disturbance, hypokalemia, and catecholamine surge. Typically asymptomatic, rapid, irregular pulse ECG, 3 or more than 3 P waves forms, and atrial rate more than 100 per minute. Correct? Underlying disturbance. AV nodal blockade like verapamil if persistent. MAT is supraventricular tachyarrhythmia that is likely due to atrial conduction triggered by the disturbance such as right atrial enlargement, catecholamine surge, electrolyte imbalance. It is the most commonly seen in elderly more than 70s. MAT is more than 70. In ECG, in MAT, M-A-T, 3 word. That means 3 or more than 3 P wave forms. And heart rate is more than atrial rate. That means P interval is more than 100. So all the MAT is like the P theory. That means MAT has 3 P, more than 3 P waveform, and the actual rate is more than 100. Correct the underlying disturbance, why it is happening, like if it is due to sepsis, if it is hypokalemia, and mostly the COPD exacerbation. Pharmacological rate control by calcium channel blocker like verapamil and cardioselective beta blocker metoprolol is indicated in MAT only when rapid ventricular leading to myocardial ischemia or congestive cardiac failure. When arrhythmia persists, despite management of the underlying disturbance, beta blocker may worsen bronchospasm in patients with exacerbation of the COPD so should be used with caution. So non-selective beta blocker should not be used. Cardio-selective beta blocker should be used. This is MAT. What I have said in case of MAT, 3 or more than 3 p-wave morphology. This is one morphology. This is another morphology. This is another morphology. Like this is one morphology. This is one morphology, and this is one morphology. There is 3 morphology, and if I count the pp interval, it is more than 100, and it is irregular RR interval. Assalamu alaikum. Now, atrial fibrillation. What happens in atrial fibrillation? Pathogenesis is atrial remodeling due to age-related myocardial change and atrial enlargement from heart disease. Age-related myocardial change or atrial enlargement from heart disease like hypertension and MS. It may be a foci of rapid electrical activity. Commonly originate This one is very high yield. It commonly originates in the pulmonary veins. This atrial fibrillation commonly originates in the pulmonary vein. Alcohol intake and increased sympathetic drive may contribute. Asymptomatic or palpitation with or without dyspnea, fatigue. There is irregular pulse. We can remember this, and may present with thromboembolic event like stroke. This is high yield. It may present with thromboembolic event. ECG may show variable RR interval and no P webs. ECG may show variable RR interval and no P web. There is continuous ECG often needed for continuous ECG often needed for paroxysmal disease. In paroxysmal or intermittent AFib, you need continuous ECG. Atrial fibrillation is the most common sustained cardiac arrhythmia, and affected patients usually have underlying heart disease like hypertension, coronary artery disease, left atrial enlargement. The prevalence of the atrial fibrillation increases dramatically with age. Approximately 70% of the affected age is more than 65. AVNRT and AVRT are the type of paroxysmal supraventricular tachycardia. The AVNRT and AVRT are type of paroxysmal supraventricular tachycardia. These arrhythmias typically present with the episodes of palpitation, dyspnea, pre-syncope, or syncope. These are the conditions where there is atrial fibrillation can happen. There may be we can we can divide it and according to the cause. There may be cardiac, pulmonary, and miscellaneous cause. Cardiac cause, first of all, hypertension, hypertensive heart disease, coronary artery disease, rheumatic or valvular heart disease, mitral stenosis, mitral regurgitation, congestive cardiac failure, hypertrophic cardiomyopathy, congenital heart disease, and post cardiac surgery. Lung cause is obstructive sleep apnea, one of the important cause. This one is very important cause. There may be pulmonary embolism, COPD, acute hypoxia, and the other is most important, obesity. There may be hyperthyroidism, diabetes, and alcohol abuse. These are the causes of atrial fibrillation. There are some drugs, amphetamine, cocaine, and theophylline can cause atrial fibrillation. These can cause atrial fibrillation. condition that increase the risk of atrial fibrillation. This can be divided according to some causal logic precipitants like conduction remodeling, and there is trigger that increase automaticity. There are some precipitants of atrial dilation like advancing age, systemic hypertension, mitral valve dysfunction, left ventricular failure, coronary artery disease, obesity, and sleep apnea and chronic hypoxic lung disease. These are the conduction remodeling, and triggers increasing automaticity is hyperthyroidism, excessive alcohol use, increased sympathetic tone, acute illness or cardiac surgery, and sympathomimetic drugs. It increased the automaticity, The drugs increase automaticity. Surgery can increase automaticity. Excessive alcohol use, hyperthyroidism can increase automaticity. If I divide the cause, there may be hypertensive heart disease, coronary artery disease, valvular disease, congestive heart failure, hypertrophic cardiomyopathy, and post cardiac surgery. These are the cardiac cause pulmonary in or in pulmonary COPD, obstructive sleep apnea, COPD, and acute hypoxic pneumonia. And the miscellaneous is obesity, endocrine is hyperthyroidism, diabetes, and alcohol abuse. So there are some drugs. Chronic hypertension is the most common morbidity associated with atrial fibrillation is most strong factor. This atrial fibrillation are RR irregular, absent PF, RR regular, they are irregular RR in ECG, irregular rhythm, variable RR, absent P wave. What are the management? Rate control, rhythm control, rate versus rhythm control strategy, and preventing systemic embolization. Urgent clinical cardioversion should be done in hemodynamically unstable patient. Hemodynamic stability evidenced by a myocardial ischemia, new onset chest discomfort or significant heart failure like pulmonary edema, pulmonary edema, and urgent electric cardioversion should be done. Stable patient, beta blocker, non-dihydropyridine calcium channel blocker, digoxin to control the ventricular rate and rhythm control. In a sinus rhythm should be considered in patient unable to achieve adequate heart rate control in those with recurrent symptomatic episode like palpitation, lightheadedness, dyspnea, and angina, and heart failure symptoms. In such a case, you should do rhythm control. Beta blockers are recommended initial therapy in atrial fibrillation due to hyperthyroidism. Atrial fibrillation should be continued until the patient becomes euthyroid. Thiamide, radioiodine, or surgery. Atrial fibrillation is the most commonly caused by ectopic foci from the pulmonary vein, which is very high L. This is Schwarzbach's score to estimate the risk of thromboembolic risk. Schwarzbach, congestive heart failure, hypertension, both has one number. Congestive heart failure, hypertension, and age more than 75 is 2, and age 65 to 74 is 1. That's diabetes has stroke TIA. It has 2 point vascular disease, prior myocardial infarction, peripheral artery disease, aortic valve. prior myocardial infarction, peripheral artery disease, and aortic plaque. Age 65 to 74 has 1 point, and 6 category. If it is male, has 1 point. Sorry, if 6 category is female, it has 1 point. So in Chadsworth score, if 0, nothing should be done. In 1, intermittent, none, is aspirin or oral anticoagulant can be given. If it is 2, then high, oral anticoagulant should be. If score is 2, oral anticoagulant should be given. Valvular atrial fibrillation or mechanical prosthetic valve. Valvular atrial fibrillation or mechanical prosthetic valve. What is the drug of choice? Warfarin. Atrial fibrillation in the setting of MS, which carries higher thrombogenic risk of non-valvular atrial fibrillation. In this score is used in non-valvular atrial fibrillation. Vitamin K antagonist, oral anticoagulant like apixaban, dabigatran, rivaroxaban, edoxaban to reduce systemic embolization risk, similar or superior efficacy of warfarin, with decreased risk of severe bleeding, hemorrhage, or no routine INR monitoring should be done. The lone atrial fibrillation, occasionally used for patients with paroxysmal, persistent, and permanent atrial fibrillation with no cardiomyopathy or structural disease or structural heart disease or structural Chadsworth score 0. Patients with lone atrial fibrillation, generally age less than 60, by definition Chadsworth score is 0. The risk of embolization in such patient is extremely low and anticoagulant therapy is not indicated. Okay. Now atrial flutter. Atrial flutter. It is approximately the atrial rate is around 300 per minute. The ventricular response can be constant or variable. In here there is irregular rhythm. There is a constant 3:1 ventricular response at 100 per minute create irregular appearing rhythm. Atrial flutter usually results from large re-enter circuit involving the cavo-tricuspid isthmus. This word is very high. Atrial flutter is a cavo-tricuspid isthmus of the right atrium. It usually results from large re-enter circuit involving cavo-tricuspid isthmus of the right atrium. Risk factors are similar to those with atrial fibrillation include coronary artery disease, hypertension, heart failure. Atrial flutter carries the similar risk of arterial thromboembolization of the atrial fibrillation should be similarly managed with chronic anticoagulation. It is managed with anticoagulation. Management also involves rate control, which can sometimes difficult to accomplish with medications along metoprolol and verapamil. Definitive management often requires radiofrequency ablation to disrupt the re-entered circuit, and electrical cardioversion is also sometimes an option. Intravenous intervention these intervention increase the risk of thromboembolic event, should be preceded by several weeks of anticoagulation therapy. This is flutter wave. This is in natural flutter. This is flutter wave. 2:1, 2:1 flutter wave. Now tachyarrhythmia. What are the adult tachyarrhythmia algorithm with pulse in advanced cardiac life support? In advanced cardiac life support, assess appropriateness for clinical condition, heart rate more than 150 per minute, and if there is tachyarrhythmia, identify and treat the cause, maintain patient airway, assist breathing, oxygen, cardiac monitoring. Persistent tachyarrhythmia causing hypertension, altered mental status, signs of shock, ischemic chest discomfort, and acute heart failure. If yes, if there is persistent tachyarrhythmia causing hypertension, altered mental status, signs of shock, ischemic chest discomfort, and acute heart failure, yes, synchronized cardioversion should be done. Sedation if regular, sedation if regular, narrow complex tachycardia, give anti-nausea. If persistent tachyarrhythmia with hypertension, altered mental status, signs of shock, acute heart failure, synchronized cardioversion. If no, and coverage duration is more than 0.12 seconds, yes, IV access and 12 lead ECG. Consider adenosine if regular and monomorphic. Consider antiarrhythmic infusion. Consider expert consultation. If QRS duration is more than 0.12 seconds, there is no, and then IV access and 12 lead ECG, vagal maneuver, adenosine beta blocker or calcium channel blocker, and consider expert consultation. Patient with persistent tachyarrhythmia, narrow or wide complex causing hemodynamic instability should be managed with immediate synchronized cardioversion. Whenever possible, patients should be provided with adequate sedation and analgesia prior to cardioversion. It is used in symptomatic or sustained monomorphic VT and hemodynamically unstable atrial fibrillation with rapid ventricular response. Unsynchronized cardioversion defibrillation, which provides a high energy shock at a random point in the cardiac cycle and is used during resuscitation efforts in patients with pulseless cardiac arrest with shockable rhythm, ventricular fibrillation, and pulseless ventricular tachycardia. In patients who do not have hemodynamic instability, adenosine and vagal maneuver should be. If hemodynamically instability, synchronized cardioversion. Unsynchronous cardioversion or defibrillation. Unsynchronous cardioversion, also known as defibrillation, which provides high energy shock at a random point, is used in ventricular fibrillation and pulseless ventricular tachycardia. Pulseless VT and VFib, unsynchronized cardioversion or defibrillation should be done. But synchronized cardioversion in done in hemodynamically unstable patient and in no hemodynamic instability patient adenosine vagal nerve. IV antiarrhythmic amiodarone procainamide can be used in stable, recurrent, refractory, white complex tachycardia. IV antiarrhythmic procainamide, digoxin can be used in rate control in supraventricular arrhythmia. Atrial flutter, atrial fibrillation, and tachycardia, especially in patients with hypertension and heart failure who are unable to tolerate beta blocker and calcium channel blocker. Carotid sinus massage is useful vagal maneuver to terminate paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia is a regular narrow complex tachycardia. Atrial premature beat or premature atrial conduction is a benign arrhythmia. In here, the irregular rhythm, different P wave from AC node generated P wave. Different P wave morphology is seen in here. Is usually asymptomatic. It happens due to alcohol, caffeine, stress is identified and should be avoided. Beta blocker are often helpful in symptomatic patient. In symptomatic patient, beta blocker is in sustained monomorphic VT, white complex tachycardia with fusion beat. White complex tachycardia with fusion beat are usually diagnosed as sustained monomorphic VT. In here there is fusion beat. In VT there is two beat called fusion beat and capture beat. This is very pathognomonic sign for diagnosing VT. Patients with coronary heart disease and left ventricular systolic dysfunction are increased risk of ventricular arrhythmia including VT and sustain. Approach to a patient with white complex tachycardia. If there is AV dissociation, the white complex tachycardia, if a dissociation fusion or capture will present or not. If no, consider SVT. If yes, think about diagnosis of the ventricular tachycardia. If it is stable, IV amiodarone. If it is unstable, VT. Hypertension, altered mental status, respiratory distress. If it is present, synchronized cardioversion. If it is SVT, if it is stable, vagal maneuver, cardiac sinus massage, these should be rate control drugs. So AV dissociation fusion or capture with diagnosis of the VT if stable, IV amiodarone unstable, synchronous cardioversion if it is SVT stable, vagal maneuver, monomorphic VT. This is the fusion beat capture of electrical signal through both atrium and ventricle briefly, a hybrid of normal and white QRS complex. Hmm, a hybrid of normal. This is white QRS complex. This is white QRS complex, and this is normal QRS complex. Hmm, a hybrid of normal and white QRS complex. This is capture fusion bit. This is fusion bit. Sustained monomorphic VT IV amiodarone is preferred. Other antiarrhythmic like procainamide, sotalol, lidocaine are reserved for who do not respond to amiodarone. Antiarrhythmic can convert the sustained monomorphic VT into sinus rhythm. Avoid the need for urgent electrical cardioversion. This is VT, white complex tachycardia, white QRS complex. This is white QRS complex. Heart rate more than 100, white QRS complex. Ventricular arrhythmia, premature ventricular arrhythmia, including ventricular premature beats, non-sustained ventricular tachycardia, and ventricular fibrillation are quite common. Immediate post-myocardial infarction period. Ventricular fibrillation is the most frequent underlying arrhythmia is responsible for sudden cardiac death in the setting of acute MI. Most of patients, 50% can occur for ventricular arrhythmia and for immediate post-infarction period. This is ventricular fibrillation. This is white QRS. No identifiable QRS in here. Chaotic irregular waveform. Chaotic irregular waveform. This is white QRS, but this is not white QRS. It is a non-identifiable P-wave QRS complex ventricular fibrillation. Arrhythmia occur within 10 minutes of the coronary occlusion are known as immediate or phase A ventricular arrhythmia. Acute ischemia causes heterogeneity of the velocity in delayed activation, and delayed or phase 1B arrhythmia occur 10 to 60 minutes after the infarction, result from abnormal automaticity. In patient with pulseless VT, immediate defibrillation should be done. Long QT, prolongation, ever anti-arrhythmic group 1A, 1A, 1C, and 3. Anti-arrhythmic amiodarone, euthyroid, anti-arrhythmic antibiotic, antibiotic, antipsychotic, antipsychotic, antidepressant, tricyclic antidepressant, and other SSRI. Anti-anginal, ranolazine, anti-infective, antibiotic, antipsychotic, antidiarrheal, antiemetic, antifungal. Metabolic cause, low potassium, magnesium, and calcium. Bradyarrhythmia, sinus node dysfunction, heavy block, other hypothermia, HIV infection, and the inherited Romano no deafness, Romano Wars syndrome, and Jarvis Nelson syndrome. He has deafness, autosomal recessive, Romano no deafness, autosomal dominant, QT prolongation more than 450. Patients with congenital long QT syndrome. In here, beta blocker, propanolol dampen the sympathetic activity, reduce the risk. Implantable cardiac defibrillator replacement or left cardiac sympathetic denervation also appropriate for high risk. Immediate defibrillation is indicated. Immediate defibrillation is indicated in hemodynamic unstable patient. IV magnesium in first line therapy is in conscious and stable patient with causes. This sudden cardiac arrest, time elapsed prior to resuscitation, prolonged CPR more than 5 minutes, absence of vital sign, advancing age, prior history of cardiac, prolonged CPR more than 5 minutes to chronic illness, persistent coma after CPR, need for intubation or vasopressor, pneumonia, renal failure after CPR, sepsis, cerebrovascular accident. The most common cause of sudden cardiac arrest in ventricular fibrillation, ventricular tachycardia, pulseless cardiac arrest with a shockable rhythm, pulseless cardiac arrest with a shockable rhythm. The most critical factor determining overall patient survival is elapsed time to effective resuscitation. These include CPR, prompt rhythm analysis, early defibrillation mm, in a shockable rhythm. This is approach to cardiac arrest. Approach to patient with cardiac arrest start CPR, give oxygen, monitor attachment, defibrillator attachment. If it is ventricular fibrillation or pulseless VT, then shock. CPR in 2 minutes, obtain IV excessive asystole or pulseless electrical activity. Uh, CPR in 2 minutes, IV access, epinephrine in 3 to 5 minutes, and possible advanced ERS. Shockable rhythm. If there is shockable rhythm, shock. If there is shockable rhythm, then shock. If there is no shockable rhythm, there is asystole in pulseless electrical activity also. In shockable rhythm, no CPR in 2 minutes, straight for reversible cause. Shockable rhythm, yes, shock. CPR in 2 minutes, IV amiodarone, treat the reversible cause. Shockable rhythm, yes, shock. CPR in 2 minutes, epinephrine. Approach a patient with cardiac, adult cardiac CPR, give oxygen, pulseless VT, defibrillation, shock. Pulseless electrical activity, CPR in 2 minutes, IV oxygen, epinephrine. Pulse rhythm check every 2 minutes, test of reversible causes are sustained. Shockable rhythm, return of spontaneous circulation, and unshockable rhythm. In unshockable rhythm, pulses electrical activity, inheres CPR, airway. This is the reversible causes of asystole or pulseless electrical activity. 5H and 5T, hypovolemia, hypoxia, hydrogen ion acidosis, hypovolemia, hypothermia. Then tension pneumothorax, tamponade, toxin, thrombosis, and trauma. This is sick sinus syndrome, elderly patient, bradycardia, fatigue dyspnea, bradycardia, tachycardia syndrome. There is sinus bradycardia, sinus pauses, sinustral block. This is bradycardia. If heart rate is less than 60, rhythm regular, P present, IV atropine should be given. Approach a patient with sinus bradycardia if a pulse is less than 50, symptomatic dizziness, assess application, identify IV access, cardiac monitoring, pulse oximetry with oxygen. If persistent bradyarrhythmia of one of the hypotension, one of the following hypotension, alternate mental chest discomfort concerning cardiac acute heart failure, no monitoring. If hypotension, altered mental status, chest discomfort, ibuprofen 0.5 milligram bolus, repeated 3 to 5 minutes, up to 3 milligram maximum. if IV atropine and if IV atropine 0.5 is bolus dose, then it is escalated up to 3 milligram. If it is no response, transcatheter spacing or IV development 2 to 10, IV epinephrine no response, consider expert consultation. Okay, that's all for today. Hope you enjoy.